Module 7, Chapter 20. In Chapter 20, we're going to finish up our cardiovascular system by talking about your blood vessels and circulation. Now, there are several types of blood vessels that you're going to hear about in this particular chapter. You have arteries, capillaries, and veins. Now, the one thing reliable about your arteries is that they always carry blood away from the heart. Now, there are different types of arteries that we're going to be discussing. The largest arteries are referred to as your conducting arteries. You have the fewest number of these. The conducting arteries, though few in number, send out numerous branches that continue out into other body areas, and these branches are called distributing arteries. The distributing arteries then branch, forming more numerous resistance arteries. The resistance arteries then have numerous branches so that you can form even more arterioles, which are your smallest of arteries. Now, the arterioles deliver blood to another blood vessel type called a capillary. Now, your capillaries are more numerous than either of the other vessel types. They are also the smallest. And as the smallest, these capillaries are going to be your exchange site, meaning they have the ability to exchange material between blood and interstitial fluid. Now, once you have exchanged, blood is going to now need to return to the heart. And the one thing reliable about your veins is they always carry blood in the direction of the heart. So your very numerous capillaries are going to start merging together to form fewer and slightly larger postcapillary venules. The postcapillary venules then merge together, forming fewer but larger muscular venules. The muscular venules then merge together, forming fewer but larger medium veins, and then these medium veins merge together, forming fewer but larger large veins. Now, before moving forward, I do want to mention the vasa vasorum. The vasa vasorum is a unique set of blood vessels that actually service the walls of your larger blood vessels. So these vessels are bringing oxygen and nutrients and taking away waste and CO2 within the walls of the very large blood vessels, like the superior and inferior venae cavae, the aorta, and the pulmonary trunk. Now, blood vessel walls have a typical construction pattern, meaning they have three similar layers. The innermost layer is called the tunica intima. The tunica intima consists of an endothelium, which is simple squamous epithelium, and its associated basement membrane, and a thin layer of areolar connective tissue. The tunica intima is going to surround something called the lumen, which is the opening inside the vessel where blood flows. Superficial to the tunica intima, you have the middle layer of your vessel wall, which is called the tunica media. Now, the tunica media has smooth muscle, it has collagen, and sometimes even elastic connective tissue. It serves to strengthen the wall of the blood vessel and aid in regulation of blood vessel diameter. Now, you're going to hear two terms used quite frequently in this series of modules. There's vasoconstriction. Vasoconstriction means that the smooth muscle within this wall has contracted and as a result has decreased the diameter of the blood vessel. You're also going to hear the term vasodilation. Vasodilation is when this smooth muscle relaxes, allowing for an increase in the diameter of the blood vessel. The outermost layer of the vessel wall is called the tunica externa. The tunica externa is made out of areolar connective tissue, so it's got a good bit of elastic and collagen protein. The tunica externa helps to anchor your blood vessel to adjacent tissues. It also serves as a passageway for the small nerves, lymphatic vessels, and the vasa vasorum servicing the blood vessel walls. Now, your arteries and veins do share these three layers to the vessel wall, but there are some structural modifications between the two types. For example, arterial walls have a much larger or thicker tunica media. By having a much thicker layer of muscle within the wall, arterial walls tend to be a lot stronger, and they're capable of significant amounts of contraction. So they're great pumpers. With regards to the veins, their tunica media is really thin, so their walls tend to be a little bit weaker because they don't have that sturdy muscular support. And it also implies that they really don't contract and create force well. Now, on the flip side, the veins do have a much larger or thicker tunica externa than arteries, and that's for a little extra strength and support. The thicker tunica externa is basically compensating to a degree for the reduced amount of muscle within the vessel wall. If you compare arteries to veins, with regards to their lumen size, the arterial lumen is more narrow compared to the vein, so veins have larger lumens. The reason your arterial lumen is smaller is because there is elastic recoil within the tunica media, and it kind of keeps that lumen smaller. Because arteries have these really great super strong walls, they tend to retain their circular shape in section. So if you were to remove the blood from an artery, it stays nice, round, and open. Veins, on the other hand, because they don't have those nice strong muscular walls, if you take the blood out of them, like you would need to prepare a section for microscopic study, the veins tend to collapse, so they look more flattened. If you look at the endothelium, so next to the lumen of both types of vessels, the arterial lumen actually has a pleated appearance due to the contraction of smooth muscle, so just due to the normal muscle tone within that wall. Since veins have very little muscle, they don't have a high degree of muscle tone, and their endothelium tends to be more smooth. Arteries are much more resilient. When stretched, they tend to keep their shape and elongate, and then when you release the stretch, they tend to snap back very easily to their original shape without any damage. This again is due to those nice, sturdy muscular walls. Veins, on the other hand, with their weaker walls, tend to tear if they're stretched and collapse. In addition, they tend to not recoil back to their original shape and size as easily. Veins also possess a structure that arteries do not have, or capillaries do not have for that matter. Within their lumen, they possess venous valves, and these valves are going to help maintain one-way blood flow toward the heart through your veins. You'll learn in a future module that these valves are necessary because blood pressure within your veins is extremely low, and some assistance is needed to help maintain one-way flow back to the heart. Lastly, if you start thinking about pressure, arteries do have much higher pressure compared to veins because your arteries receive blood at a high pressure from your right and left ventricles. So now let's take a look at your different types of vessels with a little more detail. And we'll start with your arteries. Now, as mentioned on the previous slide, arteries have lots of muscle, so they're capable of great amounts of vasoconstriction and vasodilation. And these capabilities have very important effects. They can affect afterload on the heart, because vasoconstriction and vasodilation can alter peripheral blood pressure. And you learned in the heart chapter that if you increase systemic blood pressure, it's going to be a lot harder to open the semilunar valve, which is an increase in afterload. Your ventricles will have to contract with greater force to reach a pressure high enough to open the valve. Your arteries also, because they can constrict and dilate, can regulate blood flow into your capillaries as well. Now, your first group of arteries are the largest. They are referred to as conducting arteries. However, they are also referred to as elastic arteries. And I do tend to like elastic because it describes what they do a lot better than the word conducting. Now, with regards to these arteries, they do have the largest diameter. And if you look at their wall, specifically the tunica media, they have a really high proportion of elastic fibers and less smooth muscle compared to all of your other vessels. So they're the largest, and with all of that elastic, they're going to be the stretchiest. And these arteries have significance because they're going to act as a pressure reservoir. Now, during ventricular systole, remember you are ejecting blood at very high pressure into your arteries. The elastic arteries have the ability to expand quite easily to accommodate this huge surge of blood coming out of the heart at a very high pressure. Now, during ventricular diastole, their function truly shines. Because remember, during ventricular diastole, your ventricles are not contracting and blood is not being ejected from the heart. And if that's the case, what's maintaining blood flow throughout all of the arteries in the body? What's maintaining your blood pressure? And it is your conducting arteries. What these arteries will do is that they're going to exhibit what's called elastic recoil, meaning they expanded and stretched during ventricular systole as that big surge of blood came in. And then when your ventricles are relaxing, the walls of those arteries begin to recoil, creating pressure, and continue that forward push of blood throughout your arteries. So it is your conducting arteries that actually maintain pressure and blood flow while your ventricles are in their diastole. Now, the elastic arteries are very low in number, but they are strategically placed. Your aorta, which is sending blood throughout the entire body, it's managing all of the systemic circuit. Your pulmonary trunk, which is the large artery that begins your pulmonary circuit. The common carotid arteries, which are sending blood flow up into the neck and head. The subclavian arteries, which are carrying blood into their respective shoulder and upper limb, and the common iliac arteries, which are directing blood into the pelvis and the lower limb. So if you think about those positions, these arteries, thanks to their elastic recoil, maintain blood flow into the head and neck, into the upper limb, into the lower limb, into the pulmonary circuit, and then throughout all of the other organs in the body when your heart is in that relaxation phase. Now, the distributing arteries, also known as muscular arteries, are about medium in size, so they are smaller than the conducting arteries. They branch off of the conducting arteries themselves. So think of the conducting arteries as tree trunks, and the muscular arteries are the branches coming off of that tree trunk. So they are smaller, but more numerous than the conducting arteries. Now, the reason these vessels are referred to as muscular arteries is that they have a high amount of smooth muscle, up to 40 layers of smooth muscle in some cases, and much less elastic compared to the conducting arteries. Because of that, these vessels are capable of tremendous vasoconstriction and vasodilation. Now, the vasoconstriction and the vasodilation are going to help adjust both the rate and volume of blood flow to different organs in the body. So think of these arteries as distributing blood to specific organs of the body. So they help to prioritize blood flow. The kidneys might get more blood flow when you're resting and relaxing, but then your skeletal muscles get more blood flow when you're exercising. So they help to distribute blood volume, which, by the way, is why they're also called distributing arteries. Our next arteries are the resistance arteries. Now, they're very small arteries that do branch off the muscular arteries. The wall of the resistance artery can vary in composition depending on how big it is. The larger resistance arteries still do have all three wall layers. The largest ones have up to 24 layers of smooth muscle. Now, usually these have very little elastic protein, so they're definitely more muscular. And if you compare the thickness of the tunica media to the diameter of the lumen, the tunica media is actually thicker than the diameter of the lumen. Now, the smallest resistance arteries are called arterioles. Arterioles are the smallest of the resistance arteries. They have only about 1 to 3 layers of smooth muscle in the tunica media, and they have little to no tunica externa. So their walls are getting a lot thinner. However, they do still have some muscle, and they play a very important role in regulating blood flow from your arteries and into your capillaries. They do this by regulating something called resistance. Resistance is an opposition to blood flow, and it's created by friction between the blood within the vessel and the wall of the vessel, so the tunica intima. So as the blood is flowing along the tunica intima, it creates friction, and this friction is your resistance to flow. Now, how it's regulated by the arterioles is when they vasoconstrict and vasodilate. If your arteriole vasoconstricts, that means it's going to decrease the size of the lumen of the arteriole. Now, if the lumen is smaller, it means that the blood passing through that lumen is actually making more contact with the actual tunica intima, creating more friction, more drag, more resistance. The more resistance you have, the less blood flow you have into the capillaries. Also, there is going to be a corresponding increase in blood pressure. Try to imagine it as you have a volume of blood, you're trying to push it through a teeny tiny hole, and you're going to need more pressure in order to maintain flow. If you do vasodilation, the lumen of the arteriole gets wider, meaning that the blood passes, if you think about the volume of blood passing through that vessel, the majority of the blood volume is passing through the center of the vessel and makes no physical contact with the tunica intima. In fact, comparatively, very little volume makes contact with the tunica intima. The less contact that the volume has with the wall, the less friction and resistance there is with that volume. Now, if resistance goes down, you have an increase in blood flow into your capillaries, and there's a corresponding decrease in blood pressure. Think of it as you don't have to push as hard to get a volume of blood through a giant opening. Now, when you start thinking about the arteries, there are 3 different arterial sense organs that you also need to be concerned with. because they're going to play a role in the regulation of things like blood pressure at the end of this chapter. The first sense organ I want to mention is called the carotid sinus, and you do have two of them. Each carotid sinus is located in the internal carotid artery, just above the branch point from the common carotid artery. Now, the carotid sinuses are baroreceptors, meaning they're going to respond to stretching in the wall of the carotid sinus. You then have the carotid bodies, which are also near the branch point off of the common carotid. The carotid bodies are chemoreceptors, so they're monitoring things like blood pH, oxygen, and CO2. Aortic bodies, which are located in the aortic arch, are also monitoring chemical changes, so they are chemoreceptors as well. The next group of vessels that we're going to talk about are your capillaries. Now, these are the smallest vessels that exist in the body, and they are barely the diameter of a red blood cell, so they're very, 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 very small. The walls are composed of tunica intima only. In fact, they're only composed of the endothelium and an extremely thin basement membrane. The reason that this is important is because these vessels are your exchange vessels. So you learned in A&P1 that diffusion occurs faster across a very thin barrier. Well, nothing is thinner than simple squamous epithelium. So having this extremely thin wall is going to allow the capillaries to perform their job. Now, there is a capillary within about 60 to 80 microns of every cell in the body. So the majority of your cells are right next to the blood supply. Now, how many capillaries you actually have within a tissue varies with the metabolic activity of the tissue. If the tissue has higher oxygen and nutrient requirements, you're going to have higher numbers of capillaries to accommodate the exchange of those materials. If your tissue has lower metabolic requirements, meaning it requires less oxygen and nutrients to support its activity, you'll have fewer numbers of capillaries. Now, it's rare to find a capillary all by itself. In most places of the body, capillaries are going to form networks called capillary beds. So these capillary beds, imagine them in your head as looking like the most woven fishnet stockings, fishnet spider web that you have ever seen. Now, there are some areas of the body that don't have capillaries at all. So things like your cartilage, your lens of the eye, the cornea of the eye, and your epithelial tissues. All four of these are lacking capillaries. The question is why? Well, cartilage is used as a cushion in the skeletal system, and cartilage takes a lot of abuse. Every time your bones move at a joint, you've got that cartilage right in between the bones. Well, you don't want blood vessels in that tissue because you don't want to risk bleeding every time you move a joint and there's impact to the cartilage. The lens and the cornea of the eye are the clear windows that allow light to enter the eye and get to the retina so that you can see. If you had capillaries within those two structures, it would obstruct light entering the eye and you would not be able to see or not be able to see as clearly. Your epithelial tissues, like the beautiful stratified squamous epithelial tissue that forms your epidermis, cover the surfaces of all of your organs, basically every surface of the body. And remember from A&P1, it's the surfaces that have the greatest risk of damage. So if you're on a surface that is at risk of damage, you don't want to have blood vessels there because you don't want to bleed every time the surface has impact or has physical contact with something. Now, when you deal with tendons, which are the structures connecting muscle to bone, and ligaments, which are connecting bone to bone, they have very scarce capillary beds, so there's a little bit of blood flow, but not much. Again, part of the reason that it's more restricted with regards to the number of capillaries is because your muscles are constantly tugging on the tendons, your bones move, and your ligaments are constantly getting stretched. And again, you don't want to risk bleeding every time you move because those structures are being stressed and blood vessels could rupture. However, you do need to make sure you have some blood flow because these structures do take a lot of abuse, and everything that you need in order to support repair is carried by your blood. So you do need to have some blood supply coming in. The poor level of blood supply, though, is why the repair and the degree of healing that you have in tendons and ligaments is unpredictable. It can vary from person to person. Now, when you start thinking about your capillaries, there are two major types of capillaries. The first is called a continuous capillary, and these are the most common. What you have in a continuous capillary is a continuous lining of endothelial cells. And these endothelial cells are held together by intermittent tight junctions. So they're not completely connected by tight junctions because that would create more of a zip-locked effect where materials would not be able to pass across the capillary wall. But you do need to have them held together, so you do have some intermittent tight junctions. However, there are gaps in between the cells where you do not have those tight junctions, and those gaps are called intercellular clefts. And those intercellular clefts are going to play a very important role with regards to the exchange of materials. Now, some capillaries possess things called pericytes. Pericytes are cells that actually wrap around the outside of the capillary. They do contain contractile proteins, so it is believed that they might potentially play a role in regulating capillary blood flow, but they're not sure. They do know that the pericytes can become endothelial cells or smooth muscle cells to help with growth and repair, both of the capillaries and in surrounding tissues. Now, with regards to where they are in most body regions. Again, they are the most common. They are permeable to all lipid-soluble materials, so the lipid-soluble vitamins, any chemical in the lipid family, oxygen, carbon dioxide, alcohol, anesthetics like ether and chloroform, and the injectable anesthetics they use in surgery now. They're also permeable to very, very small solutes up to the size of glucose and amino acids. So from ions up to those other building blocks, you are small enough that you can pass across this wall. Now, there are specialized areas in the body where the continuous capillaries have extremely restricted permeability, because you don't just have intermittent tight junctions, you have a full complement of tight junctions, basically zip-locking all of the endothelial cells together. Now, one of these areas you learned about in A&P1, the blood-brain barrier, zip-locking all of those continuous capillaries within the central nervous system, protecting your neurons from the toxic for neuron components that are inside the blood. This year, you're going to learn about the blood-thymus barrier and your blood-testis barrier. Other areas where you have extremely restricted exchange between blood and the interstitial fluid. The next category of capillaries are your fenestrated capillaries. Fenestrated capillaries possess things called fenestrations. Fenestrations are extra pores that you have in the plasma membrane of the endothelial cells. These pores have larger diameters than the intercellular clefts, and these pores pass all the way through the cells. So by adding these larger, basically holes, you have the ability to actually move larger things across fenestrated capillaries. In fact, you can move chemicals up to small peptides. Remember, peptides are 2 or more amino acids linked together. So we can move a few larger things. However, you cannot pass plasma proteins or the larger formed elements across this wall. So these capillaries allow more to move, but you still can't move those very big things. Now, fenestrated capillaries are in strategic areas of the body. They're not very common. You do find them in the choroid plexuses within the ventricles of the brain, and that's so that you can actually move cerebrospinal fluid and its larger components from the endothelial cells, or pardon me, from the ependymal cells and into the ventricle. You find them in certain endocrine glands like the hypothalamus, the pituitary gland, the pineal gland, and the thyroid gland. These glands make hormones that are a little bit larger, and you need to be able to get those hormones from the glandular cells and into the blood. So you have to be able to get them into the blood so that they can travel through the body and actually have an effect. You have them in your intestinal tract to accommodate the absorption of larger nutrients. And you have them in the kidney filtration sites to help you with filtering larger waste products and other chemicals in the blood out of the blood and into a structure called the nephron, which is the filtering unit within the kidney. Now, there is a third type of capillary. It is a type of fenestrated capillary, so it's not its own category. It is called a sinusoid capillary. It is a modified fenestrated capillary. They are more flattened with very irregular outlines, allowing them very easily to conform to the shape of your tissue. They do possess fenestrations and intercellular clefts, just like the fenestrated capillaries, except they're even larger. So the pores through the cells are bigger, the gaps between the cells are larger, and these capillaries basically are permeable to everything. So formed elements can pass across, plasma proteins can pass across. So these are extremely leaky capillaries. And because of this, you only put them in areas of the body where that particular ability to exchange is needed. For example, you need them in the liver. The liver is your source of plasma proteins. So you need to be able to move plasma proteins from the interstitial fluid of the liver and into the blood so that they can transport around the body. You have them in your bone marrow. And remember, your red bone marrow is where you actually make the formed elements. So if the formed elements are made in the bone marrow, they have to be able to cross the capillary wall in order to get into the actual blood itself, which is why you have sinusoid capillaries there so that those formed elements can cross the wall. You'll be learning in the lymphoid chapter that your spleen also has sinusoid capillaries because your spleen is involved in the phagocytosis of red blood cells when they reach their 120-day age. So if you've got an old or damaged red blood cell in the blood, it has to be able to pass across the capillary wall in the spleen in order to be phagocytized. So these capillaries accommodate that function. Your spleen also helps with phagocytosis of foreign particles and potential pathogens as well. So you need to be able to have those things leave the blood. Your spleen is where you store a significant amount of your platelets. So once the platelets are formed in the red bone marrow, they cross the wall of a sinusoid capillary to get into the blood, but then they're going to have to cross the wall of a sinusoid capillary in the spleen in order to be stored there. There are even some glands that produce hormones that are so incredibly large that you need to have sinusoid capillaries in order for the hormone to enter the blood at all. And these hormones come from glands like the pituitary gland and your adrenal gland. Now let's talk a little bit about the anatomy of your capillary beds. On the screen, you've got on the left an arterial, on the right a venule, and a capillary bed between the two. Now, one arterial can lead to the formation of dozens of capillaries that drain into venules at the end of the capillary bed. Many capillary beds do possess, running through their center, direct connections between the arterioles and the venules, so that you can actually bypass blood flow into the capillaries if needed. Now, the first portion of this direct connect actually comes off of your arterial. It's called the metarterial. And it's unique because it still has some scattered smooth muscle cells in its wall. It's not a tunica media like in the arterial, but there are still some smooth muscle cells wrapping around it. Now, this metarterial is the link between the arterial and the capillaries. So the metarterial helps to carry blood from the arterial to the capillaries. This metarterial also helps to form the direct connect from the arterial to the venule. Now, if you follow that metarterial, about halfway through the capillary bed, the smooth muscle cells in the wall disappear. And when the smooth muscle in the walls disappear, the direct connect is changed from being called a metarterial to a thoroughfare channel. So what they have colored blue is that thoroughfare channel. The thoroughfare channel is receiving venous blood, is receiving deoxygenated blood from the capillaries, and that thoroughfare channel then connects into the venule to begin the transport of blood back to the heart. Now, it is important to note that not every capillary bed has a full direct connect between the arterial and venule. In some cases, the capillaries do connect directly into the venule, so there is no thoroughfare channel component to that capillary bed. Now, let's talk about how blood flow is actually regulated into a capillary bed. Now, some of the regulation is created by the vasoconstriction and vasodilation of the arterioles, as mentioned before. However, there is also regulation of blood flow within the capillary bed itself. There are little structures called precapillary sphincters, and you can actually see those precapillary sphincters on the figure where the metarterial sprouts the capillaries. If you look at the figure, it looks like right along the metarterial there are these large rings, and the capillary is emerging from those rings. The precapillary sphincters are rings of smooth muscle, so they do have the ability to vasoconstrict and vasodilate. Now, if the precapillary sphincters vasodilate, you allow blood to flow into the capillary bed. However, if you vasoconstrict the precapillary sphincter, you close the opening between the metarterial and the capillaries, which is going to stop blood flow into the capillary bed. Now, within the body, only about 1/4 of all of your capillaries have any flow at any one point in time. And so that means periodically you do have flow within the bed, and then the next moment you don't have blood flow in the bed. And this regulation of flow is actually at the level of the tissue itself. It's basically in response to chemical changes within the interstitial fluid surrounding the capillary bed itself. All right, now let's turn our attention to our last vessel type, your veins. Veins are often referred to as capacitance vessels. To understand this phrasing, you need to understand a little bit about the wall of your veins. The walls of your veins, as described before, are very thin. And because they don't have a lot of muscle, there's not a lot of tone in the wall, which makes them very flaccid. Now, it's okay for veins to have these really thin walls because they have extremely low pressure, so there's not a lot of force pushing outward on the wall, and blood flow within your veins is steady. It's not pulsatile or pulsating like in the arteries where you have a high systolic and a lower diastolic pressure. Now, because these walls are very thin, they have the ability to expand easily to accommodate an increase in blood volume. Okay, their walls don't offer a lot of resistance to stretch, which also means that they have a greater capacity for blood containment compared to arteries. So the reason they're called capacitance vessels is because they have this greater capacity for holding larger blood volumes. Now, the diagram that we have here on the screen is actually showing the distribution of your overall blood volume. And as you can see, it's not very proportional. Your systemic circuit does hold about 84% of your blood volume, but if you compare the different types of blood vessels, 64% of your whole blood volume is in your veins of the systemic circuit. Your systemic arteries only carry about 15% of your overall blood volume. Capillaries only 5% of your overall blood volume at any point in time. Your pulmonary circuit, surprisingly, only holds about 9% of your volume, and the heart only 7% of your volume. So your veins, as capacitance vessels, really do hold a significant amount of blood volume. Now, with regards to your veins, they do have a little bit of muscle in their walls, so they are capable of venoconstriction, so constriction of the smooth muscle in their wall. It's not the most robust constriction compared to the arteries, but this venoconstriction can reduce venous blood volume. Now, if you constrict the veins, they're going to push blood volume out of themselves. So you're going to be pushing blood out of your systemic veins. That volume has to go somewhere, which means that volume is going to go into your systemic arteries, it's going to go into your systemic capillaries, your heart, your pulmonary circuit. And in the case of an emergency, this venoconstriction can help maintain appropriate blood volume and blood pressure in these other areas of the body. So it's going to help maintain blood volume in the heart so that your heart is ejecting the amount of blood that it's supposed to. It's going to maintain the flow in blood volume and pressure in the arteries, which are carrying oxygenated blood to your body tissues. It's going to make sure you've got enough volume in your capillaries so you have adequate exchange throughout the body. It's going to make sure you have more volume heading into the pulmonary circuit to get rid of CO2 and pick up oxygen. So your veins, very, very helpful in cases where you've had blood loss or a significant drop in pressure. Now, there is such a thing as the venous reserve, because within that 64%, about 20% of your blood volume is found within the systemic veins of the liver, the systemic veins of the skin, and then also in the veins of the pulmonary circuit. So you've got a huge amount of volume in just 3 small areas. So that's why these areas are referred to as your venous reserve, kind of this backup supply of this huge volume of blood. It's also why if you physically damage the skin, you can bleed so excessively because you have so much extra volume stored in your skin. It's why when you damage the liver, you bleed so excessively internally because of how much blood volume is stored there. So let's start talking about your veins by starting with the smallest of veins, your postcapillary venules. Postcapillary venules are going to receive blood from your capillaries directly or through thoroughfare channels. Their wall consists of tunica intima and some scattered fibroblasts, but they are lacking muscle. Now, these venules are more porous than capillaries, which allows for you to have some fluid exchange across these vessel walls. And most importantly, these are the blood vessels that allow you to have white blood cell emigration. Remember, white blood cell emigration was the process in which a white blood cell would actually squeeze between the cells of the vessel wall in order to enter your body tissue. The postcapillary venules then merge together to form less numerous but larger muscular venules. Muscular venules have about 1 to 2 layers of smooth muscle in their tunica media, and they do have a tunica externa as well. The muscular venules will then merge together to form less numerous but larger medium veins. Now, the medium veins consist of most of the veins with individual names. So things like the popliteal vein, femoral vein, brachial vein, radial vein, most of the veins, in fact, that you're identifying in your vein lab. Now, these particular veins have a very thin tunica media and a very thick tunica externa, typical of all of your vein walls. However, in the tunica media, rather than a continuous layer of smooth muscle, the smooth muscle tends to exist more in bundles. These veins are also the first veins to possess venous valves. A venous valve is composed of tunica intima, so it consists of just a layer of simple squamous epithelium, and those valves are responsible for preventing blood backflow in your veins. This is needed because the pressure in your veins is extremely low and in some cases might not be enough to prevent backflow. Now, the medium veins will merge together and form larger, less numerous large veins. Now, the large veins actually do have some smooth muscle in all 3 layers, but they do maintain the typical vein wall construction with the small tunica media and the larger tunica externa. Examples of the large veins are the venae cavae, renal veins, pulmonary veins, and internal jugular veins. There is another type of vein. It's referred to as a venous sinus. The venous sinuses have very thin walls, extremely large lumens, and no smooth muscle whatsoever. You've already seen an example of this semester, that lovely coronary sinus that receives blood from your other heart veins and returns it to the right atrium. You were also introduced to the dural sinuses which are in the skull that collect blood from the brain and then carry that blood out of the skull by sending it into the internal jugular veins. You'll be identifying the different dural sinuses as well in the vein lab. Now, before we leave this section, I do want to talk a little bit more about those venous valves. Because they're made out of just simple squamous epithelium, the venous valves can be very easily damaged due to an increase in pressure on them. And that could lead to things like varicose veins. Varicose veins are dilated and twisted veins resulting from leaky valves that allow blood volume to accumulate inside of the vein. The vein then swells as the volume accumulates, and in the superficial veins of the skin, primarily in the lower limb, they start to have this very visible spiderweb appearance, which is why some people call them spider veins. Now, varicose veins could be congenital in cause. Some people are just born with weaker venous valves than others. So if there is added pressure on the valve, it becomes damaged more easily. However, varicose veins can occur in everybody due to changes in mechanical stress. For example, if you're sitting, crossing your legs where your knee is pressing on the popliteal region of the other, long-term standing where you're not moving around much. In these situations, you are impeding venous return from the lower limb or a portion of the lower limb. And if you prevent blood flow in the veins, they start to accumulate a much larger volume because of the lack of flow. And that increase in volume increases pressure on the valves, and consistent pressure on those little valves made out of simple squamous epithelium very easily can damage them. Now, if the varicose veins occur in the anal canal, they're referred to as hemorrhoids. So hemorrhoids are just dilated and twisted veins due to backflow in this particular body region. What you see on the screen are the extremes of hemorrhoids, where these veins have become so incredibly swollen that they're actually protruding from the anal canal. Now, before we leave this chapter, I do want to talk about the different types of circulatory routes that exist in the body. Now, the most common circulatory route is the one that involves blood leaving the heart, flowing through an artery, passing through one capillary bed, through a vein, and back to the heart. However, this is not the only type of circulatory route. In a portal system, you actually have blood flow through two capillary beds before it goes back to the heart. So the route would go heart, artery, capillary bed 1, vein, capillary bed 2, vein, and back to the heart. The hepatic portal system will be explored in lab because it allows for you to purify blood coming from areas like the small intestine before it enters systemic circulation. In lecture, you will learn about the hypophyseal portal system, which allows for the hypothalamus to exert control over pituitary gland function. You then also have a circulatory route referred to as an anastomosis. An anastomosis is a convergence or merging between two vessels that are not capillaries. In an arteriovenous anastomosis, you have blood from an artery passing directly into a vein outside of a capillary bed. So it's a complete capillary bed bypass. These anastomoses allowed for very quick rerouting of blood out of an organ in order to get it to another body region as quickly as possible. For example, if you're becoming too cold, you can actually use these anastomoses within the skin to pull blood out of the skin quickly and reduce heat loss across the skin into the environment. A venous anastomosis is actually the most common type of anastomosis. So we're going to be merging veins together. And in a venous anastomosis, you're providing alternate routes for blood removal from a body region. So what would happen is if you have blockage in a vein, you could actually take the blood from that body region, reroute it through other veins in order to maintain blood removal. In an arterial anastomosis, you're going to have two arteries that are called collateral vessels merging together to supply blood to the same capillary bed. And what this allows is an alternate route for blood delivery to a tissue. This is significant because if one collateral vessel becomes blocked, you still have oxygen and nutrient delivery to that tissue through the other collateral vessel. The most important arterial anastomosis in the body is the cerebral arterial circle, which services your cerebrum. What happens is if you have a blockage in one of the supplying vessels to the cerebrum, the basilar artery or one of the two internal carotid arteries, you can reroute blood through the cerebral arterial circle to ensure that the entire cerebrum maintains blood flow and oxygen delivery, nutrient delivery. However, most of the arteries in the body are referred to as end arteries. An end artery is one artery that delivers blood to just one set of capillaries within a tissue. This is significant because if you block the end artery, its tissue now no longer has oxygen and nutrient delivery, and that will lead to tissue death if the blockage is not removed. Now, I mentioned that cerebral arterial circle is an anastomosis that helps to maintain blood flow throughout the cerebrum if one of those three supplying arteries is blocked. The arteries that come off of the cerebral arterial circle migrate into the cerebrum and send out more branches. All of those arteries are end arteries. So if your blockage occurs after you have passed through the cerebral arterial circle, you will lose oxygen and nutrient delivery to a segment of the cerebrum, and that tissue will die unless the blockage is removed fairly quickly.